Okay, dear viewers, I'm Dr. Rakesh Gupta. I'm President Sipher and former Director Health Services Punjab. We welcome you all for the Clean Shot series by Docplexus, and I feel honored to have with us an eminent Vitreo-Retinal consultant, Dr. Gaurav Sanghi. He's a founder member of the Sangam Netralaya Superspeciality Eye Care, Mohali, Punjab. So this is our new series of ClinShot, your clinical dose of short and focused discussions for you, our healthcare practitioners who do not have much time to spare. We have started this short series with discussions every month for the benefit of specialists in the field. So you can watch us live every Tuesday, 6 p.m. exclusively on Docplexus. So diabetic retinopathy is one of the most common complications of diabetes. And as you all know, India is a diabetic capital. So affecting it actually affects nearly 95 million people in India. And despite significant advances being made in the treatment of this condition, it remains the leading cause of vision loss worldwide. Proper patient education about the associated risk factors, along with timely diagnosis and implementation of the management strategies, they are the key to reduce the incidence and improve the overall prognosis of the disease. So welcome to the 5th episode of our Clean Shots on ophthalmology with Dr. Gaurav Sanghi. We'll be talking about diabetic retinopathy. So Dr. Gaurav Sanghi, he is a Vitreo-Retinal consultant, as I told you, and also he is founder member of the Sangam Netralaya Superspeciality Eye Care, Mohali. He did his MS ophthalmology from PGI Chandigarh, India in 2006, and he was a senior resident and a senior research officer at Advanced Eye Center in PGI Chandigarh. He has worked as a Vitreo-Retina consultant in Grewal Eye Institute in Chandigarh and Center for Sight in Chandigarh. And March 2014 onwards, he is now a Vitreo-Retina consultant at Sangam Netralaya Mohali. He has won the prestigious GM Pava Award for the paper entitled OCT Characteristics, an outcome in optic disc pit maculopathy at the 19th Annual Conference of Vitreo-Retina Society of India. It was in December 2010, and his field of expertise is Vitreo-Retina, experience in treating diverse medical and surgical vitreoretinal conditions, including complex pars plana vitrectomy surgery and retinal detachment surgery. And he has also a lot of experience in retinopathy of prematurity, experience of treating one of the largest number of babies with retinopathy of prematurity in North India. So you're welcome, Dr. Gaurav. You may please give your presentation. Thank you.
Good evening, everyone. So I will like to immensely thank Dr. Rakesh Gupta and Docplexus for giving me an opportunity to talk about diabetic retinopathy. So as Dr. Rakesh Gupta has already mentioned, that diabetic retinopathy is one of the commonest morbidities which diabetic patients face over a period of time. So without wasting much time, so we go ahead with the presentation. So as we all know, diabetes is a multi-system disorder caused by lack of insulin or resistance to insulin. So there are two types of diabetes mellitus: type 1 diabetes due to lack of insulin, and type 2 diabetes, which is also called as non-insulin dependent diabetes mellitus. So if we look at the incidence of diabetic retinopathy, so if there is insulin-dependent diabetes mellitus, so usually at first examination and within 5 years, diabetic retinopathy does not develop. Followed by 10 years, nearly 30% of IDDM patients, they develop diabetic retinopathy, and by 15 years, the incidence increases to 75%. And as far as non-insulin dependent diabetes mellitus is concerned, at 5 years, NIDM, in NIDDM, diabetic retinopathy can be present, and at 10 years, the incidence increases to 25%, and at 15 years, it can increase to 60%. So if we look at the prevalence of diabetic retinopathy, in various diabetic clinics, it has been reported as varying from 4 to 28%, and in retina clinics, 50 to 75% of prevalence of diabetic retinopathy is seen. So usually there are like two types of changes in diabetic retinopathy. The stage 1, which is called as non-proliferative diabetic retinopathy or NPDR, and the stage 2 is the proliferative diabetic retinopathy or PDR. So we just understand the pathology behind it. So the first stage is called as the non-proliferative diabetic retinopathy. So what happens in this is that it is basically a capillary microangiopathy. Here we can see that from the capillaries there is loss of pericytes, and this causes saccular outpouchings from the endothelial wall. So these saccular outpouchings are called as microaneurysms. So usually they will leak and they cause retinal edema. They will leak lipids, causing hard exudates in the retina. They will bleed, causing dot and blot hemorrhages. So we are subsequently seeing the various changes. So the earliest changes are microaneurysms, which are like red dots. We can see here, and this is a more prominent. Then, so in this picture, we are seeing these microaneurysms, and they are leaking, causing hard exudates on the retina. And once we have a progression of hard exudates, so we have various succinate rings of hard exudates along with swelling in the retina, which we call as macular edema. And in very advanced stages, we can have multiple rings of hard exudates and dense deposits of lipids, which may approach the central foveal area, and this is also associated with swelling of the retina. So this is a case of advanced non-proliferative diabetic retinopathy with macular edema. And normally both eyes are affected. However, the disease can be asymmetric, with one eye having more changes and the other having lesser changes. Now the second stage is called as proliferative diabetic retinopathy. So here the basic pathology is dropout of the capillaries. So there is capillary closure. So in response to capillary closure, what happens? There is retinal hypoxia. And in response to hypoxia, there is arteriovenous shunting. So shunt vessels form, and they appear on the surface of retina as intraretinal microvascular abnormalities, or IRMAs, what we call them. And there may be release of vasoformative or vasoproliferative substances like vascular endothelial growth factor. And these drive neovascularization on the surface of retina. We can have neovascularization on the optic disc, or neovascularization away from the optic disc, which is called as neovascularization elsewhere. And in later on stages, this can also cause rubeosis of the iris. So this is an example of neovascularization on the optic disc. So here we are seeing, fine network of blood vessels, these cartwheel-like appearance of blood vessels, so which appear on the surface of retina. So these are new vessels which are fragile, and they are ultimately going to leak blood. Now, if the new vessels appear away from the disc, more than one disc diameter away from the disc, they are called as neovascularization elsewhere. And this is an example of neovascularization elsewhere, where we are seeing a fine network of these abnormal blood vessels which are leaking, causing a pre-retinal bleed. Now, when they bleed, so we can have vitreous hemorrhage, which can vary from a milder form, or we can have a dense vitreous hemorrhage, like in this case. And in later on stages, attractional retinal detachment, which involves the foveal area, central foveal area, can occur. So what are the symptoms of diabetic retinopathy? So most patients may not have any symptoms till significant damage occurs. So patient may see blurred vision whenever they have symptoms. By that time, a lot of significant changes may have happened on the retina already by the time the patient presents to us. So if there is, proliferative diabetic retinopathy, which causes a bleeding on the surface of retina, so patient may notice scotomas like this, multiple scotomas in the field of vision like this. So this means, usually the patient has bled at this point of time. So what are the investigations? So basically we begin with a slit lamp examination. We put dilated drops in the eye 30 minutes prior to examination. And every diabetic, at least once a year, he needs a dilated fundus examination to pick up diabetic retinopathy early. So if we notice that there are some changes like macular edema or proliferative diabetic retinopathy, so we do some ancillary investigations. So first one is the optical coherence tomography. So optical coherence tomography, this provides a cross-sectional image and thickness of the retina. So now a normal optical coherence tomography OCT of a normal retina will look like this. So this is the central area, this is the foveal area, which is normally concave and it's dipped towards the center. So if we have swelling in the retina, we call it as macular edema. So this is a case of swelling in the retina. So this is one of the cases with diabetic macular edema. This swelling in the retina on OCT may present as various patterns. So like this is an example of a spongy retinal thickening, where there is a lot of intraretinal edema. So the swelling may assume the shape of cystoid changes, which is called as cystoid macular edema. Another pattern can be accumulation of fluid beneath the retina, which we call as subfoveal serous retinal detachment. In some cases, there can be a fibrous membrane over the surface of retina, which causes pull on the retina, and this causes a macular edema. So this is called as a taut posterior hyaloid membrane. And in later on stages where there is extensive proliferative diabetic retinopathy, we may end up having a tractional detachment of retina. This is an example of tractional detachment of macula. We can see this is subretinal fluid, right? And in cases, there may be a premacular hemorrhage, and OCT helps us to delineate the area of premacular hemorrhage. Now, the other investigations is a fundus fluorescent angiography, where we inject fluorescent dye and we take digital images after injecting the dye, the images of the eye. So fundus fluorescent angiography will tell us about the various abnormalities of the retina. Like here, we can notice this is a case of proliferative diabetic retinopathy. So we are seeing various changes here. Like this is a area of abnormal neovascularization, which is leaking. Again, this is an area of abnormal neovascularization on the surface of retina. We are seeing this area where we have no capillaries. So this is called as CNP area, or capillary non-perfusion area. We are also seeing these numerous small dots. These are called as microaneurysms. And we are seeing various distorted capillaries, which is called as capillary microangiopathy. So FFA, or fundus fluorescent angiography, helps us in delineating various abnormalities in the retina, and accordingly we can treat the patient. So what is the role of systemic investigations? So a battery of systemic investigations are important in diabetic retinopathy. So we begin with first is the HP. So because if the patient has anemia, the patient will be more prone to hypoxic injury and more severe diabetic retinopathy. 3 months sugar control, that is HbA1c, is important. Also the fasting and postprandial sugar profile is important. Again, if the patient has a high LDL level or a high cholesterol level, a deranged lipid profile, they will have more severe diabetic retinopathy. So other thing we order is blood urea, serum creatinine, blood pressure. Again, the patients who have uncontrolled blood pressure are more prone to diabetic retinopathy, more prone to develop bleeding if they have proliferative diabetic retinopathy. And what is important, blood urea, serum creatinine may be normal. So what we need to also order is 24-hour urinary protein, which tells us about early effects on the kidney. And if the patient has proteinuria, usually the macular edema is more severe in these patients. So all these investigations are very important. And the physicians have a very important role, because we need the physicians for good overall control. Not only the sugar control is important, correction of anemia is also important, correction of cholesterol, especially the role of statins is important if the patient has diabetic macular edema, correction of BP, as well as if the kidney profile, renal functions are deranged, they need to be corrected. So let me go back to the slide. Now, drug history is important. Certain anti-diabetic medication, especially the glitazones, pioglitazone and rosiglitazone, they have been linked to the worsening of diabetic macular edema. So we should also keep in mind, if the patient has diabetic macular edema and is on any of these drugs, so we need to stop this drug. Now, the treatment of macular edema, the various choices are laser treatment, intravitreal injections. Of course, we cannot overemphasize the role of systemic control, as well as we need statins. And in certain cases, if there is a tractional macular edema, we need surgery. So the laser treatment for macular edema, the first one is the focal laser. So focal laser is generally done if we have a succinate ring of hard exudates, or if there is a non-center involving macular edema. Like here, we are seeing this succinate ring of hard exudates. So we have applied in this limited area these laser spots to prevent leakage in this area. Now, to show you an example, so this is a case where we have a single succinate ring of hard exudates along with swelling of the retina. So in the center of this, we have applied focal laser, and a few months down the line, so all these hard exudates as well as retinal edema has resolved. Of course, we have combined this with statin, that is atorvastatin, which will take care of these hard exudates. Now, if we have more pronounced changes, like we have multiple succinate rings of hard exudates and macular edema, so we apply these laser spots in a C-shaped pattern. This is called as a grid laser treatment. So the benefit of grid laser treatment is that sometimes the patient may not be able to receive intravitreal injections. And in these cases, grid laser alone may cause dramatic reduction in macular edema, like in this patient where we had a severe, non-proliferative diabetic retinopathy and a lot of subfoveal fluid. There was a dramatic reduction in the macular edema as well as the subfoveal fluid just by doing grid laser alone. This is another case where we just did grid laser, gave atorvastatin, and there was resolution of all these hard exudates and macular edema. But all these cases are not like that, because a significant proportion of patients will have a central involving and massive diabetic macular edema. Here, laser treatment may not work, so we need other strategies. So if we have a central involving macular edema, usually the choice of treatment is intravitreal injections, which are of mainly two types. First one is the anti-VEGF agents, which like bevacizumab, ranibizumab, aflibercept, and the latest addition, this is a brolucizumab, which has recently been approved by DGCI for use in diabetic macular edema. And the other option is a steroid implant, and the one available in India is called as a Ozurdex implant. So we'll just come one by one to all this. So we have certain important questions. When to treat center involving macular edema and which drug to use? Usually when the vision is good, vision is more than 20/40, usually we may observe the patients of macular edema. However, if the vision is 20/40 or less and the patient has a central involving macular edema, we do need to treat it. And the choice is between intravitreal injections like bevacizumab, ranibizumab, aflibercept. All these drugs are effective. However, various clinical trials, especially this is data from Protocol T, here they have compared all these drugs, bevacizumab, ranibizumab, aflibercept, and they have shown that if the initial visual acuity is between 20/32 and 20/40, any of the three drugs, bevacizumab, ranibizumab, aflibercept, will work. equally efficaciously. However, if the visual acuity is 20/50 or worse, aflibercept will be more effective at improving vision. Now, the other question is how many injections do we need for treating macular edema? So, usually, most of the trials they recommend monthly injections for the first 6 months. Our real world scenario here in India, where patient may have cost constraints as well as other issues for follow up, we make sure that at least the patient receives 3 doses of intravitreal injections for the first 3 months and followed by intravitreal injections whenever the patient has a recurrence of swelling. So just to show you various examples. So like this is a patient who has macular edema. And this is a case where the macular edema is not very much. So we can say it is like a moderate kind of macular edema. And a couple of injections, the patient, there's response to intravitreal injection. And here we may not need multiple injections. Or we may have a case where the macular edema may be massive. And this is a OCT scan at baseline. And this is a scan after a couple of injections. And still we have significant amount of swelling. So this patient is in for a long haul, may need multiple injections over a period of time. Now, the other thing is that certain patients may not respond to anti-VEGF injection. So here, these patients, especially if the patient is having an intraocular lens that is pseudophakia, or there is a marked increase in macular thickness, or the patient is non-responsive to anti-VEGF drugs, like in this patient. So here we have used this, what we call as a sustained release dexamethasone implant, which is a biodegradable implant. And here we can see that after injecting this implant, within a couple of weeks, this macular edema, all these cystoid changes, they have resolved. And usually the effect of this implant lasts for 4 to 6 months. After that, we may need to repeat it if the patient again develops a macular edema. Now, in certain cases, we may have tractional macular edema where we see tractional membranes over the surface of retina, like in this case. So here we do a pars plana vitrectomy surgery. So here we are injecting intravitreal triamcinolone to stain the fibrous membrane. Now, so with a combination of various techniques, like this is the vitrectomy cutter, we are peeling off this tractional membrane. Now, after lifting up this tractional membrane, we are using this intraocular forceps to lift up the tractional membrane from the surface of the retina. Here. Now we can see this membrane being peeled over from the surface of the macular area. And the remaining membrane is being trimmed with the vitreous cutter. And this is the hyaloid being lifted up from the surface of the optic disc. So this is and again, these are peripheral membranes which are also peeled off from the surface of retina. We are seeing a small periretinal bleed here. And this periretinal bleed is aspirated with a silicone-tipped cannula. So this was a patient. So these are the pictures from this same patient. So this is a pre-op OCT. Here we can see a tractional membrane on the surface of retina, lifting up the retina, causing macular edema. The vision was 6/60. And this is a month down the line. The foveal contour has come back to normal. The visual acuity has improved to 6/24. Now, coming on to the proliferative diabetic retinopathy, the various options are pan-retinal photocoagulation, intravitreal injections, mostly bevacizumab and ranibizumab, and surgery if we have tractional retinal detachment involving the macula or vitreous hemorrhage. So this is an example of neovascularization of retina. Like in this patient, we can see there is a neovascularization underneath this pre-retinal bleed, and these are the laser spots where we have done a pan-retinal photocoagulation. So pan-retinal photocoagulation, why it is called pan-retinal photocoagulation? Because we do this procedure in 3 settings, and we laser all the peripheral retina. So these are the laser scars of all the peripheral retina, leaving the central macular area behind. So this is called as pan-retinal photocoagulation, which is done when we have neovascularization of the retina, either on the disc or in the neovascularization elsewhere, or we have a pre-retinal bleed. Now we can have a patient where we have a mild vitreous hemorrhage, or we can have multiple areas of neovascularization. So here we do PRP laser, but also we combine it with intravitreal injection. Like in this patient, we have done a bevacizumab intravitreal injection. So this is the photograph before the injection, and this is the resolution of this pre-retinal bleed after bevacizumab injection. Now, what are the indications for surgery in proliferative diabetic retinopathy? Surgery is usually recommended if we have a non-resolving vitreous hemorrhage nowadays. We may wait for up to 1 month if the vitreous hemorrhage is not resolving. So we do a vitrectomy. If there is a recurrent vitreous hemorrhage, then also surgery is indicated. Sometimes the hemorrhage may be very, very dense, which is not likely to go away, especially if it is a premacular or subhyaloid hemorrhage, then also surgery is indicated. Or if there is a tractional detachment involving the macula, so then also surgery is indicated. So let us take up some of the examples one by one. Now, so this is a short 2-minute video clip showing the various steps of surgery from basically a case with vitreous hemorrhage due to proliferative diabetic retinopathy. These are the various entry ports for our instruments. So the first step is we do a clearing of the core vitreous, and here we are removing subhyaloid bleed. So we are cutting the vitreous. So the aim of the surgery is to remove all the tractional membranes as well as bleeding. Here we are removing the premacular cortical vitreous. And here we can see the bleed on the surface of retina. These are the tractional membranes on the surface of the optic disc. So this is the intraocular forceps. We are using the intraocular forceps to lift up these tractional membranes from the surface of the retina. Now, here it is being lifted gently from the surface of the retina. Now, once this membrane is lifted from the surface of retina, so we trim it with a vitreous cutter. Now, with a silicone-tipped cannula, we remove all the pre-retinal bleed from the surface of the macula. So we are seeing that here the macula is gradually being cleared up. So this is the optic disc here. And once the pre-retinal bleed is cleared up, so now here the fovea is visible. The fovea is healthy in this patient. So here we are doing laser treatment. Here we are completing pan-retinal photocoagulation. Now, these are the images from the same patient. So the presenting visual acuity was corny fingers, and after surgery, finally the vision improved to 6/6. So we can have various other conditions, like this patient with proliferative diabetic retinopathy. He went on from this stage to this stage. Here, the patient had a dense premacular hemorrhage. The visual acuity was reduced to hand motions close to face. So these are the images after the surgery. So finally, the visual acuity improved to 6/9. And we may have a case where we have a lot of these tractional membranes on the surface of retina, and this is a tractional retinal detachment involving the macular area. And this is an image after the surgery. Now here we have removed all these tractional membranes. We have done more pan-retinal photocoagulation. These are the laser scars. Finally, the patient vision did improve to 6/36. At least the patient is ambulatory, he can move around. So in most of the patients, diabetes is a lifelong disease. Some patients, you need multiple interventions. It's just not that we did one intervention and everything is all right. A lot of these patients, because they have severe diabetes, so they need multiple interventions. Like this is a case with proliferative diabetic retinopathy along with massive macular edema, representing visual acuity by 6/60. So here we first did a PRP laser, then we did an intravitreal bevacizumab injection and did a vitrectomy surgery. The visual acuity improved to 6/18, still had massive macular edema, still had massive macular edema. Now in this patient, we did an Ozurdex implant. At this point of time, the visual acuity was 6/18. A month down the line, the visual acuity improved after Ozurdex implant as the macular edema settled down to 6/9. In between, the patient underwent intravitreal bevacizumab injection and focal laser, also underwent a cataract surgery along with bevacizumab laser, finally achieved a visual acuity of 6/12. Again, the macular edema starts to show up. Again, we injected Ozurdex implant. The vision finally improves to 6/9 partial. So in some patients, we do need multiple interventions to maintain good visual acuity. So what is the schedule of follow-up for all these patients? So if we have a normal examination like this, if we have a normal fundus like this, once a year is good enough. If we have mild kind of non-proliferative diabetic retinopathy, every 6 months follow-up is required. If we have moderate non-proliferative diabetic retinopathy, like in this case with a succinate ring of hard exudates, every 2 to 3 months follow-up is required. And once we have severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathies, depending on the situation, every 1 to 2 months follow-up may be required, depending on case-to-case basis. So, but eye examination after dilation is must for all diabetic patients. So to summarize, so what is important is routine examination of all diabetic patients for early detection. Our physician friends should all send the diabetic patients to ophthalmology and the retina specialists to do a dilated examination, very important. And the ancillary investigations like OCT scan and angiography is also important. A good medical control where we control not only the diabetes but also the hypertension, the lipid profile, kidney function, correction of anemia. So all comprehensive control is important to effectively manage diabetic retinopathy. So various treatment options involve intravitreal injection, laser treatment, and once we have more advanced stages of proliferative diabetic retinopathy, surgery is indicated. Our diabetes is a lifelong disease, and we need a continuous follow-up, both for the diabetes as well as continuous eye examinations to maintain vision in these patients. So thank you very much.
So it was pleasure listening to you, Dr. Gaurav, and it was a very useful presentation for general physicians as well as general ophthalmologists. So if they refer diabetic retinopathy patients even before the diabetic retinopathy sets in, so it really makes a difference. And if the patient is anemic, maybe gestational diabetes, patient suffering from gestational diabetes, then uncontrolled diabetes, and if it is diabetes is of a very long duration, and if the patient is having hypertension, renal diseases are there, and high cholesterol is there. So these are high-risk patients. I think the general physicians and the general ophthalmologists, they will know when to refer the patient. So thanks a lot. And thanks a lot, viewers. So to our dear viewers, thank you so much for attending the session, and do share any more questions if you have. Until we see you again, take care and happy Docplexing. So thank you, Dr. Gaurav. Thank you.
Thank you, sir. Thank you so much.